Dr. Kelly. So Dr. Susan Kelly is from New Mexico. Please take it away, Dr. Kelly.
So we're going to talk a bit about what is required to create a clean environment where you have removed C. diff, some criteria for confirming cleanliness, and some of the barriers that we have to getting a good clean. So we're going to talk about why cleaning is essential. What does it take to be clean? How do we know we're clean when we can't see it? And why doesn't cleaning get done? And then what is the end result for patient outcomes? So one of the most shocking studies to me was this one that came out that demonstrated that if you, as a patient, go to the hospital and your hospital room was previously occupied by a patient with C. diff, that your risk of getting C. diff is then doubled. So that's your risk ratio there, 2.35, and it could be anywhere between 1.2 and 4.5 times as likely. So this is a little shocking, simply the random choice of the room that you get can double your risk of C. diff when you're admitted to a facility. The other issue is when you have a patient, how does it happen then? How does the C. diff get all over the room? And it's all about touching. And one phrase that I use a lot when teaching about infection control is that patients are covered with the fecal patina. And the fecal patina in somebody who is having C. diff, especially diarrhea, is going to be very heavy with C. diff, in addition to other enteric flora. And so you can culture, and of course we don't routinely culture for C. diff outside of study situations, but you can culture the skin and gloves that have touched the skin of patients and find C. diff in an alarmingly high percentage. And the more contaminated areas you go to, down from the chest to the abdomen to the groin area, the patient's skin is more and more heavily contaminated with C. diff. So we have to think about a whole new kind of cleaning that's beyond your typical household or hospital cleaning that in many instances is focused on what is gleamingly clean and, as we have at the VA, highly reflective and buff linoleum floors, to something called hygienic cleaning. So this is not sterilization, it's not high-level disinfection, but it's a level of cleaning that significantly reduces C. diff. So as we know, one of the issues with C. diff is it forms these spores that are very resistant to your usual disinfectants, and you need a bleach product or an accelerated hydrogen peroxide product to kill the spores. It also helps if you physically remove the spores. So this study showed that you could do cleaning, you could do regular routine cleaning, which reduced the positive culture somewhat. And then after you had a research team come in and do a very intensive hygienic clean, that you could achieve a much greater reduction in positive cultures. So that's with people who are focused on hygienic cleaning in research. So how do we get our cleaning staff, our hospitals, able to reach that level of a hygienic clean? So looking at cleaning overall, one big issue with hospitals is, was my room clean and quiet? This is one of the consumer assessment questions. So the clean and quiet hospital environment is there on the survey, and people tend to say, so it's quiet, big deal, because as healthcare workers, we are completely immune to the noise. I have my pager turned up really loud because over 30 years I have become completely immune to my pager. So, but we don't realize how extremely noisy and disruptive these environments are. The interesting thing about clean and quiet on the hospital patient survey is it actually correlates with the hospital's patient safety score, also on the big AHRQ CMS survey. So the challenge is, how do we maintain this environment here, which is clean and quiet, precisely because there's no patient there, and the room is empty? How do we maintain that kind of environment when we have a patient in there and we're delivering care? Of course, I could not take a photograph of any room with a patient in it because of HIPAA considerations. So measuring clean. What is clean? We can inspect. It's very subjective. We can try and be objective about the process. Are we following a checklist? Are people observing the techniques of the employees who are cleaning? Or can we measure the outcome of the cleaning, which is the environmental contamination, and see if C. diff or a surrogate marker for C. diff potentially still present? So, question for the group: how do you know room is clean? Or is this a rhetorical question? This is not a polling question. Okay, all right. Rhetorical question. So, here's the process. Ensure the right rooms get cleaned the right way with correct signage and communication with nursing staff. So this is starting to sound like the R's of medication administration. This is more challenging than it would appear. Sometimes when patients get discharged, all of the signage on their room comes down, and the staff come up to do the cleaning a little bit later, and they have no idea that it was a C. diff room or needs any particular attention in a terminal clean. So communicating with nursing staff, maintaining the signage up on the room until it is terminally cleaned is important. Checklist tools are very useful. And when I'm speaking to EMS staff, and there's any kind of pushback about a checklist tool, you can tell them that we expect our surgeons who have at least 2 degrees, if not more, to use a checklist for a fairly basic process that's maybe, 10 or 11 things long that they do several times a day. They're supposed to use a checklist in the OR to make sure they're operating on the right foot or whatever. Yet we expect these employees who have to do what's arguably just as complicated and lengthy a process. The checklist for cleaning has usually 35 elements on it. And so there's no shame in using a checklist. And then using other techniques, one that I've heard used is going from left to right consistently across the room to make sure nothing is missed. There's no shame in using checklists or reminder tools throughout healthcare. And getting our staff at every level to do that is important. So monitoring the thoroughness of cleaning, we'll talk about. It's hard to do this every time when a room is cleaned, but we use it most often, in my experience, as a training tool. And then engaging patients and families. So the subjective mode. This tends to focus on things that are not really related to patient safety. For instance, we go up and down the back stairs at the VA. There are frequently dust bunnies there. People call and complain to the cleaners, oh, there's dust bunnies on the back stairs. A dust bunny never killed any patient yet when it's on the back stairs, as far as I know. So there's a lot of cosmetic focus in cleaning because the perception is that visitors and so forth are going to be worried about dust bunnies on the stairs. What they really need to be worried about is what they're not seeing. So the subjective mode is also fault finding. It does get you attention, and I've used pictures emailed around to get attention to areas that a dust bunny does get attention, but it's not really that important. So measuring clean, you can use a UV marker solution. This will measure if the item in question has been thoroughly wiped, okay? It doesn't tell you what the result of that wiping is. And this is also a useful training tool. And the UV does work well, even in a fair amount of ambient light, and you can shine the UV light on it and see whether or not your marking is still there. And it's an eye-opener, and it reminds people to be thorough about the high-touch areas. So other ways to measure clean, people have mentioned ATP. ATP is really fun, and people like the instant feedback. And the main barrier to the ATP is managing the data. So use their data trending software. It's not an inexpensive program, and the test strips, as with every device in medicine that uses test strips, the test strips are where they seem to make their money. So this may not be feasible for many places to use in every room to test for the organic material with ATP, but it's a great training tool. When we were able to have designated cleaners and we used the ATP, they were able, over the course of several months, to get to a point on the readings where they didn't have to re-clean the room. So they had actually learned what it took in terms of cleaning to then get this very abstract kind of reading on the machine. So that was an interesting learning process in learning to be thorough, but again, something you can't always see that readily. So developing the evidence-based process, the leadership and the management and how they manage their staff is really critical. How they modify perhaps their old cleaning habits to teach not just cosmetic cleaning, but have we really dealt with the high-touch and low-touch items in the patient's room? Because those high-touch items, the call light, the TV, remote control, the bedside table, the overhead table, they will be heavily contaminated. And then developing a checklist, which can be based on the CDC's checklist, which is there on their website. So other human factors that we've dealt with: who cleans what, with what, for how long, the contact time issue, when do we use the different products, and how do we communicate this, and then how do we monitor? So a few things will come up over and over for you. Who cleans the electronics? Who cleans the desk phones? What are you going to use? Contact time, look very closely at the contact time. In a low humidity environment, which is the case for most of us on this Western call, you're not going to have liquid product there for very long. It will evaporate. So these contact times of 10 minutes and so forth may not be realistic. And then knowing your products. So you can go to the EPA website and you can look at their entire list of EPA-approved T. difficile sporicidal products. Most of these products are going to be a bleach or accelerated peroxide. Not all of them are intended for healthcare. Be careful about that. So with your vendor, look at what they offer, make sure it's on that list, but you're going to have to test with your staff, make sure you deal with the issues of odor, any perceived safety issues, and also any perceived or real skin irritation issues when these products are used. So why doesn't cleaning happen effectively? Cleaning is hard. So what can delay in trying to answer? Right, right. We'll get some answers, yeah. So recommended education for your EMS personnel. Engaging your frontline people, very important. So they have to be partners in the patient safety and have pride in what they do. And it really helps, I've found, if you have dedicated cleaners for the unit. There's accountability and relationships that are very important, and there's a two-way support that I think is very important for the cleaners. So it's an important managerial aspect. Sometimes, as at the VA, we cannot stratify the pay for our cleaners based on any particular expertise or training that they've had. So you may have to find out other ways to reward your cleaners and motivate your cleaners. Engaging patients and families. APIC came out with this sheet a few years ago that I've just summarized here. And it's very important because it talks about having a relationship with the environmental services staff as a patient. And for sometimes you go into the hospital, one of our hospitals here in New Mexico, I was so impressed. You go in and the environmental services person dropped a little card and said, if you have anything you need, get in touch with me and I will come and clean up whatever. And then the last thing here is very important. Clutter. Overflowing garbage from families bringing in, the pizza boxes. They have to have some awareness that if we are going to clean your room properly, we don't want people essentially moving into the hospital room, and that's always a challenge when families come in en masse and you can't even get in there. So they do have to work with the EMS people. So we can talk a bit about ways to engage teams. Implementing the checklist. This is just a few of, talk about how complicated cleaning is. This is just a few of the areas that you would want to hit with your cleaning checklist. And then, of course, for terminal clean, sometimes we're also dealing with curtains, walls, and more intensive cleaning of floors and around the sink. So this is not simple. The other problem is everybody gets interrupted constantly. I'm sure cleaners do too. When they're on page, they have to run and attend to something. And so you do need to know where you are on the checklist in case you're interrupted in the cleaning process. This is a sample partial listing of the CDC's tool for the checklist and what's considered high touch and low touch. It's all available on the CDC website. So getting to clean with sporicidal agents, this was one of the first studies. You can see how old this study is. But basically, they had a bone marrow transplant unit with C. diff rates. That's back when we called it CDAD, C. diff associated diarrhea. And pre-intervention was routine cleaners. The intervention, they moved to a sporicidal agent. The rates of C. diff dropped dramatically, and then they had a post-intervention when they stopped doing that. It was unusual in infection control studies to actually see this post-intervention rate go back up. That's much more convincing when you have an intervention and then you take it away and the rate goes back up. And that's really all that you've changed. So you've got to have your sporicidal cleaner. So polling, is your facility using a sporicidal cleaning agent? Yes, no, not sure. Yes, 100%. Yay! Good. We are getting there. Step one. They've actually found that if you don't use a sporicidal cleaning agent, it's really sort of like using nothing when it comes to C. diff spores. Okay. Can we get rid of the poll? I'm sure get rid of the poll. Okay. So high-touch sites, very challenging for your cleaners, especially when you have to remember doorknobs, and then you start to move into ICU rooms, which are the highest touch areas of all, with the highest stakes patients in that ICU. And here the patient is not even hooked up, and you can see all of the equipment in there. And how are you supposed to clean that? And that's where it gets very challenging between your RME, your reusable medical equipment policies, who cleans that and how, your biomedical people, and what wipes you can use on what equipment, especially as we become more and more electronic. So it takes a lot of work to develop these policies. So what works, kill and remove. This was wiping out C. diff from 2011. So basically an intervention before and after with bleach wipes. So the wiping strategy removes the spores as well as killing them. That's unlike some of the spraying strategies that may just kill them but not remove them. So it helps to remove them as well. So here's some technology that many people are implementing. We have a number of UV light technologies out there. There's UVC and UVD, and this shows the differential killing in rooms that are painted with a reflective coating paint versus without a reflective coating paint. And you can see that the UV cycle, 5 minutes with this ultraviolet C, does pretty well with a 4-log reduction in MRSA with and without the reflective light. And it does a 3-log reduction with C. diff with and without the reflective coating on the walls. So this is interesting technology. Again, like all of technologies, it's going to be expensive. Is it going to be worth your facility to add this ultraviolet technology to your cleaning armamentarium? Here's some considerations when you're evaluating these devices. Training, time and room turnover. Look at each device. How long does it have to be in there? You're going to have to train somebody to use it. You'll need signage because you have to empty the room while the UV is on. Do you have multi-bedded rooms where you can't use that? That's a problem. Maintaining the device, your contract with the vendor, incorporating it into your work processes. Overall, if you look at studies on this, using an enhanced technology like a UV light will probably give you an additional 20% reduction in your hospital onset C. diff. It's not going to be the be-all and end-all godsend to spend a bunch of money on UV, but it has to be incorporated into your other interventions. So we'll talk a bit and see if other people are using UV light technology. I think the human factors are still very, very important. Celebrating super cleaners, again, this is the managerial reward. Having nursing staff that communicate well with cleaners and vice versa. Letting them know how important they are when they do a good job. And if the room isn't properly cleaned back to the beginning, it doubles the risk of C. diff for that subsequent occupant. So now we'll go to the question session input from the group. Let's see. We have, yeah. Okay, so here's the question. Is it best practice to use a sporicidal disinfectant for cleaning of all clinical areas? Or is it acceptable to only use for identified patients and then use a different EPA disinfectant for all other areas? It's absolutely acceptable to limit your sporicidal disinfectant to individual patient rooms where you've identified a C. diff patient. So a couple of reasons for this. The sporicidal disinfectants are difficult to use everywhere because sometimes if you have multi-bedded rooms, patients will object to the bleach odor. Nursing staff will object to the bleach odor, and the cleaning staff themselves may object to the bleach odor and get a lot of skin irritation from using a lot of bleach all the time. So using it selectively is good. Where I would consider doing a unit clean would be what happens periodically with us is when we see the rate on a particular unit go up and up for C. diff, then we get worried that we have a lot of our rooms colonized just because there's so much C. diff on the unit and people are going to and fro between the rooms. And then we'll say we're going to try and get around all the rooms in this unit and do a C. diff sporicidal cleaning on all the rooms. So that's when I might expand the use of the sporicidal cleaner. There's other things that, you have to talk to your facilities people about. The bleach can be hard on vinyl. It can also be really hard on stainless steel. So that's why you may want to limit the use sometimes. So here's how many facilities use UV light regularly and have trained staff? It's kind of a polling question. Should use that for a polling question. Do you have any experience with direct line of sight UV cleaning status post-hygienic terminal cleaning? I do not. I think maybe you're asking if there's data out there about the results. And, you know, the manufacturers will show you their data that, yes, this kills. You have to pull the machine around to different areas of the room, both sides of the bed, when it's the direct line of sight UV. They can show you their experimental data that it kills. The 20% that I quoted was more when this has been used in real-life clinical settings as an additional intervention. And I think that is probably more meaningful because in addition to the machine killing, you have to have the appropriate training, the appropriate use, and the appropriate communication to make it work. So I think 20% is probably realistic. So hygienic cleaning is just the new terminology for a level of cleaning that acknowledges that we are cleaning much more than what we can see with the naked eye. We are cleaning bacterial spores. We are significantly reducing bioburden, i.e. crud, that may be dead, may be alive. We are reducing invisible crud that we can only measure with techniques like using ATP, which will measure biologic crud on our surfaces. So hygienic cleaning is taking your cleaning to a higher level than what you can see in terms of cosmetic naked eye inspection. Any other comments, questions?
Are there any questions in the queue?
Ladies and gentlemen, at this time, if you have a question, please press the number 1 key on your touch-tone telephone. Again, if you have a question, please press the number 1 key on your touch-tone telephone. There are no callers in queue.
Thank you. Well, thank you so much, Dr. Kelly, for presenting this information. I'm sure it's helped many people, and they'll have questions later on. So if we could, we'll forward you additional questions.